Hello everyone. Today we are going to discuss this motor neuron disease and what is MND. MND is a group of disorders affecting motor neurons that is leading to muscle weakness and paralysis. And ALS is the most common subtype of this. So yeah, and it can be either inherited or it can be either acquired. So the etiology, that is heterogeneous etiology. So genetic mutations contribute to different MND subtypes. And yeah, we'll further discuss about ALS also. This is also mostly unknown, that is idiopathic, but yeah, genetic and environmental factors play a major role in this, and that infections and hyperthyroidism also play their part. Yeah. So in this slide we can see the incidence is like 2 to 3 in 1 lakh, and the prevalence is 5 to 6 in 1 lakh, and the affects male more than female, and there's higher prevalence in Europeans, and the association is um, mainly sporadic, and yeah, everything. As we have discussed, that is the types of MND. If you see, there is two types mainly. There is a primary lateral sclerosis, that is only upper motor neurons are involved or affected, and the progressive muscular atrophy, whatever, that is PMA, that is only lower motor neurons are affected in this. Okay, yeah, and there is a subtype, that is ALS, that is amyotrophic lateral sclerosis, and this we will see the subtype, that is sporadic ALS, that is accounts for like 90 to 95% of the cases, and no known cause, that is unknown idiopathic etiology. And there is a familial ALS, that is 5 to 10% of the cases. There is a genetic linkage, that is SOD1, right, UB quillin linkage, that is a C9 ORF72, that is chromosome 9 open reading frame linkage, and there is a profilin 1 gene defect. So yeah, we'll see ALS, yeah, that way. And the etiology, as we have already told, yeah, the next slide, yeah, whatever, let's just venture deep down. If we see the clinical features in this MND, there is motor neuron disease, there is obviously there is a muscular weakness. There is a common symptom in like all of the MND subtypes. There is common, and this fasciculation, there is a may occur in various MND subtypes. This is also common, fasciculation. And there is spasticity that is present in PLS and in some cases of PMA. Okay, and yeah, so in this next slide, we can see this clinical presentation symptoms, what the patient presents. So I guess what is this? Having hard time reading this. Yeah, this is like isolated motor symptoms with sensory sparing. Obviously, it is a motor neuron disease, so yeah, there is a sensory sparing, and this, yeah, four motor symptoms are classified into upper motor neuron symptoms, lower motor neuron symptoms, and mixed symptoms. And the associated symptoms, what we have is like cognitive impairment and a pseudobulbar effect, and there is excessive laughing, crying, yawning. That is not under the voluntary control. Yeah, this all these things, and if we see the clinical presentations and clinical features in this ALS, the subtype, the main important type, then there is like asymmetrical onset. It starts with asymmetrical, but at the end it becomes symmetrical. Let me explain this. Wow. Asymmetrical onset of weakness is in the limb of the patient. There is a distal weakness, okay, with bulbar palsy, with pseudobulbar palsy, and the fasciculations, as we discussed, is common in MND. So this is a visible muscle twitches, and there's a spasticity, muscular stiffness due to upper motor neuron involvement, and then there is degrees, you know, more and more disease progression. There's like Babinski sign is positive, areflexia, and there is a tongue fasciculations, and then subsequently disease becomes symmetrical. It goes from distal to proximal. So whatever, if we go for the, yeah, in this we can see there is a bulbar onset limb motion, and now frontotemporal dementia is there. In the general signs that we appreciate, there is upper motor neuron signs, there is a slow speech, and palato mental reflex, and yeah, jaw jerk reflex we can do, yeah. And there's a limb onset, that is UMN, there is a upper weakness, Babinski sign, yeah, whatever we have discussed already, this is written in this, in my slide, yeah, yeah, yeah. Facial weakness, obviously, of course, slow speech, palmomental reflex, yeah, jaw jerk reflex, facial weakness, low palatal level elevation, dysarthria, tongue fasciculations, atrophy, yeah, and better. Yeah, we got a revision of this through my slide. Yes, my slide is also having a mild MND. So the diagnostic evolution, if we go, we can go for EMG, right, to detect the motor neuron abnormalities. We can go for nerve conduction studies to evaluate the nerve conduction, and we can go for MRI of brain and spine just to exclude the structural lessons, And in case of ALS, there is a further list of diagnostic criteria in ALS. If we go through, just don't go through the slides of mine. Just listen to me. It is more important. Slide is just for the, for a better presentation. But yeah, listen to my actual presentation than the slide. Yeah, in the slide also you can see this frontotemporal dementia. There is personality change. Obviously, of course, there will be behavioral abnormalities and language dysfunction, memory impairment. These are all like basic, these most of the neurological abnormalities we find this, there is a frontotemporal involvement, yeah, frontotemporal dementia. So we are not majorly focused about this. We are focused about the diagnostic criteria of ALS. So in this, there are four areas are involved mainly, like the bulbar area, cervical area, thoracic area, and the lumbosacral area. So there is simultaneous upper motor neuron and lower motor neuron with progressive weakness that exclude the alternative diagnosis. So mainly we go for the electro diagnostic testings which are needs to be done. If three of four areas are involved, that's definitely ALS. If two of four areas are involved, that's like probable ALS. And if only one area of four are involved, that's like possible ALS. Of what the four areas we have discussed, that's bulbar, cervical, thoracic, and lumbosacral. Okay, we can go for CSF biomarkers, yeah, we have counter diagnosis, yeah. So we can go for CSF biomarkers. There is an increase in the level of neurofilament light chains, and there is an increase in level of P neurofilament heavy chain, and then there is a monocyte chemoattractant protein 1, which is a marker of inflammation. These all will get through the CSF biomarkers. In the higher tertiary care, we can go for these type of test. We can go for EMG, of course. In MND, to rule out everything, we go for EMG. We go for nerve conduction studies to extend nerve function wise we have discussed, or MRI spine and brain for just to rule out other conditions and causes. So yeah, the management, there is a symptomatic treatment that is addressing muscle weakness and spasticity. Then there is a drug called riluzole, which is used in ALS and PLS to just delay the disease progression. And there is a supportive therapy like rehabilitation and assistive devices. Okay, in case of ALS particularly, if we go, there is no cure. There is just symptomatic and supportive treatment, like finger extensor splint. There is a foot drop or cuff assist device. There is a tracheostomy we can go for, and a space synthesizer there we can go it, and a gastrotomy we can do, and a riluzole we can give. There's a riluzole we have, yeah. Okay, same thing. There's a decrease, what it does is like decrease excitotoxicity. Okay, this is FDA approved drug. Then there is a drug called idaverone is the like decrease glutamate release, and we can go for a phenylbitrate and tarsudo pardon me tarudsodiol, yeah, phenylbitrate with tarudsodiol. Okay, the prognosis varies with MND subtypes with disease progression, and PMA and PLS generally have a better prognosis than ALS. And the ALS has like poor prognosis. Average survival onset is like 2 to 5 years. Okay, and there is overlapping criteria in both of these. There is a like both of them have like ALS and MND, both of them have like muscular atrophy and dysphagia. Okay, common in all MND subtypes. Okay, and in the advanced stages of most MND subtypes, there is dysphagia. So it starts with muscular atrophy, goes to dysphagia, difficulty swelling, leads to malnutrition. Yeah. So in this slide of mine where I am, yeah, we are discussing the pure, yeah, human and element, yeah. So automatic we have discussed everything. Now in my slide I have like, yeah, the other name, that is Lou Gehrig's disease of amyotrophic lateral sclerosis. Yeah. So in this also now we have written 3 is definite, 2 is probable, and 1 is possible of ALS, that out of 4. Yeah, this is like clinical presentation. There is a specific signs. Yeah. So yeah, primary dorsal interossea atrophy, and there is a abductor pollicis brevis atrophy, wasting of thinner eminences, but sparing of hypothermic eminences, very important. And differentiating from yeah, radiculopathy, sensory involvement and all. So yeah, this is a differential diagnosis, that is mimickers of ALS. Yeah, and yeah, treatment part we have already discussed. So yeah, thank you for listening, and yeah, thank you.